Welcome to Oncology Data Advisor, a digital resource for the multidisciplinary cancer team. Today, I am joined by Ms. Beth Sandy, a nurse practitioner at the Abramson Cancer Center at the University of Pennsylvania. Recently, she recorded an educational activity with us regarding updated strategies in treating non-small cell lung cancer. She's here to update us on changes, resources, and new strategies since recording and why it is vital for the healthcare team to participate in these educational activities. Thank you for joining us again, Miss Sandy. Would you like to introduce yourself and talk a bit about your research and what you do?
Yep, thanks. My name is Beth Sandy. I am a nurse practitioner in thoracic oncology at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia. I've been a thoracic oncology nurse practitioner for 20 years. And so I speak a lot about lung cancer. I have a lot of editorial duties and chairing of conferences, mostly related to lung cancer. So thank you for having me back.
Awesome, great to have you again. So first question I have for you is, since recording the activity, has there been any updates in supportive care strategies for NSCLC or results from clinical trials you would like to highlight?
Yeah, I mean, I think, in our program, we went through everything that was approved for non-small cell lung cancer as far as immunotherapy approaches. The one major thing that was approved since our program is the Poseidon data. So this is really a new frontline regimen for patients with either adenocarcinoma or squamous non-small cell lung cancer. And this is really a unique regimen because it's 4 drugs. So here you have a platinum-based doublet, which is the back cornerstone of everything that we do. But then adding both durvalumab and tremelimumab. So these are 2 different checkpoint inhibitors. So it's a 4-drug regimen. Tremelimumab is a new agent, new to the market. I think it initially got approved in one of the GI indications, but then just right after that in lung cancer. It is an anti-CTLA-4. And in this regimen, you get 4 cycles of all 4 drugs. With the 5th cycle, they actually drop the tremelimumab and do only durvalumab. And then with the 6th cycle, you get both the tremelimumab and durvalumab again. And then you only go on to receive durvalumab in the maintenance setting. So it's a fixed dosing of only 5 actual cycles of tremi. The dosing is a 75 milligram flat rate. And I think, what a lot of us think about in thoracic oncology is that, okay, here's yet another regimen of chemotherapy with immunotherapy. Where does this fit in? Here's what I would say about it. It is the only regimen where you can get 4 cycles of platinum-based chemotherapy plus dual checkpoint inhibitor. So if you're looking, for a really aggressive approach, especially in certain populations where maybe they've just progressed on a single agent immunotherapy and you want to try a dual approach, something like that might be appropriate. The other area they have data in, which is very interesting, that we don't see in the other trials with immunotherapy, is data in our patients with KRAS and STK11 mutations. So, KRAS is one of the most common things, and they parsed out their KRAS population, not just the G12C, but all KRAS. And that they typically have a little bit of a poorer prognosis on average. And what they found was that with the Poseidon regimen, they had a 25-month overall survival versus 10 months with chemotherapy alone. So 25-month overall survival is actually pretty good in that population of KRAS mutated patients where they tend to do poorer. So I would point that out. The STK11, again, is a poor prognostic biomarker that we know about. And so that population had a 15-month overall survival as opposed to 10 months on chemotherapy. Maybe it was even less, might have been like 9 months on chemo. But either way, they tend to do poor. So they did actually better than all comers in that regimen. So it seems like maybe these poor prognostic biomarkers, perhaps you need a stronger immunotherapy approach. So I think, that remains to be seen, but this is the one new big regimen that was approved since we did our programs. I think it, deserves some discussion, though I don't necessarily think this is something everyone should automatically get just because it's 4 drugs. I still think the other regimens that we're used to using, especially just the 3-drug regimens with one immune checkpoint inhibitor, I think are still very reasonable, probably less risk for toxicity and financially more cost available, and have just as good of data in the all comers, but possibly in these niche areas. This may be an area to consider using the Poseidon regimen.
Awesome. Yeah, this is brilliant information. I really appreciate it. And kind of going into all this information, why would you think it's important for clinicians to understand these results and stay updated on these new treatments for NSCLC?
Well, yeah, because there's data coming out like wildfire, especially when it comes to immunotherapy. We're going to talk a minute here about future um, immune checkpoint approaches, none of which have been approved yet. So these that I just talked about are the old ones. It's still PD-L1 and anti-CTLA-4, but I think it's important to kind of know now, looking at some of these trials where they're able to look at different biomarkers and how those populations may fare better with one or two dual checkpoint inhibitor therapies as opposed to only one. This becomes more important. So now in a patient like this, like maybe where there's STK11 or a KRAS, G13D or G12D, one that's not targetable, you might still say, oh, but this might actually make sense because I know that there's data there that they did better with this one regimen. So I think it's making us look at biomarker reports more closely, even when there's not something necessarily actionable.
Right. And going back to what you said, what we would be mentioning on, are there any current clinical trials or studies you're keeping an eye on or even participating in that you would like to mention?
Yeah, so let's talk about future of lung cancer, which, no surprise, is mostly immunotherapy. I'll before I get to that, I mean, target therapies, yes, we now have pretty much 9 unique targets that we have targetable therapies for. And even within those, like EGFR, there's the EGFR common mutations, and then there's the uncommon mutations and the exon 20 insertions, which all have different approvals. So even within some of our known mutations, we have heterogeneous mutations that we may treat differently. So very exciting. I think in the targeted realm, we will still find more targets that we can then develop drugs to treat. So that is definitely something in the future. But I think truly where we're going to find the biggest leaps and bounds of differences will be in immunotherapy approaches. So I'm going to talk about 5 different ones. We did cover this in our program with TIGIT. So TIGIT is a immune checkpoint that interacts with CD155 on antigen presenting cells, and it downregulates T cell and NK1 or NK killer cells. So the idea here being that, again, when this is present in tumors, it's tamping down the immune system. Immune system can't kill the cancer. There are 15 plus different molecules in development here. I mean, there is a lot. So this is an exciting field. A lot of people are looking at this target. Now, I think, really, I don't know that there's going to be as much single agent data here in this, but it's all about combinations. And that's what you'll hear me talk about with the other ones. It's all about combinations, putting different checkpoints together. So I think TIGIT is an exciting checkpoint. I think it's going to need to be combined with probably another immune checkpoint, plus or minus maybe chemotherapy. We will see. But this is something that's pretty far in development now. I think the name of the trial was Cityscape. We did cover it in our program. There's been some updates to it. It looks very promising in combination with PD-L1 checkpoint inhibitors. So if you didn't see it, check it out in our program, and there's updates to come. The second one I'll talk about is LAG-3. So LAG-3 is another immune checkpoint that there are several drugs that have been developed. Interestingly, some of them are monoclonal antibodies. There's actually another one too that's not a monoclonal antibody that kind of has a different delivery system. I think more based at the antigen presenting cell as opposed to on the cell surface. Again, another one that we're doing clinical trials with, that we have done clinical trials with at Penn. We are looking to combine this checkpoint with another checkpoint inhibitor to get the responses. But this is something that's also fairly far in development. Another one that I would talk about is GITR, or GITR, we call it sometimes. So this is glucocorticoid-induced tumor necrosis factor receptor-related proteins. A lot of words there. This is mostly preclinical. So a lot of these drugs are not yet in clinical trials. Maybe some are starting, but this is another one. Again, this is looking at just a very different way of targeting the immune system and the tumor cells. So something just to in your mind. And then the fourth one I'll talk about is CAR T. So not a new concept. CAR T is approved now in several different, lymphomas, multiple myeloma. I think in solid tumor, we haven't gotten approvals. There's a lot of technical difficulties. What are we targeting? And then when we try to administer it, we're getting all of this trouble and side effects and issues. So there's a lot of technical things we have to work out, but we're not giving up hope on this. We've been trying to trial this. I know we had a trial at Penn in lung cancer, and we couldn't really enroll people because it was almost nearly impossible to enroll them. Again, just based on a lot of technicalities that we're trying to work through and figure out how this best fits in that tumor, a solid tumor. So I said 5, but I think I had 4. So I miscounted. But yeah, those are the 4 I think that I'm excited about in the future. Again, the take-home message outside of CAR T, the take-home message is combining these different targets with already known targets like PD-1, PD-L1 checkpoint, anti-CTLA-4, and then just looking for new pathways for us to develop.
Awesome. Yeah, this is great information and definitely a lot of things to look forward to, which is great. So I wanted to ask you, and I know you kind of just touched on it, but if there's any milestones that you are particularly looking forward to or hopeful for to see completed or started in treatment by the end of 2023?
I don't know. I wish I had a crystal ball to say, because sometimes, I would hate to predict that, because I think a lot of times, especially with clinical trial drugs I've seen, take tremelimumab. We just talked about that, which is now approved. We've been trialing that for a long 10 years probably. And I thought, wow, I guess that drug's never going to come around. And then here it made its way into 2022. So I hesitate to say, which one. I think TIGIT's probably the one furthest down the line. And maybe the next one that's likely to get some sort of approval in a combination setting. But I never know. You just, you don't know. And there could be one that suddenly gains progress really quickly, especially, like GITR coming out of the preclinical models, mostly mouse models right now, but looking really promising. So we just never know.
Right, definitely. And final question I have for you is, as we're ending the interview, are there any resources that you think would be beneficial for clinicians that are listening in to help them stay up to date and help them stay on top of these new strategies and, like you said, the rapid fire updates of things that are going on?
There are lots of resources out there, different conferences that you can attend. Obviously we like our presentation as well. The one thing I did want to end with is supportive care. This is something that I had presented on in our original conversation. And, people are always saying, well, what are the updates in supportive care for the toxicity management of immunotherapy? And, realistically, I can't say, oh, it's magically new. We have our immunosuppressive drugs that we're still using, things like prednisone, and then, other like infliximab and other immunosuppressive drugs. So that really hasn't changed. But what I would say is that ESMO and NCCN both updated their supportive care guidelines in 2022, and probably are likely going to do it again in early 2023. So these are really the best resources to go to when you're worried about how to work up and manage some of these patients, especially some of the rare toxicities. If you go, both ESMO and NCCN have even guidelines on how to manage some of the more uncommon ones, let's say like the cardio toxicities that are uncommon. So I would really use those as good resources. I think the one thing that I've sort of done more in the past year relates to colitis, and I've been tending to use the fecal calprotectin test more often. It's a send out stool test, so it's a little bit inconvenient in that respect, but such a good marker for inflammation within the bowel, and really helping me understand where the colitis is at as I'm tapering and treating, as opposed to having to do invasive procedures. We're not even hardly doing that anymore. Initially it was all about colonoscopy and doing all this, but I don't know about other institutions, but mine takes a long time to get a colonoscopy scheduled and figure it out. By that time, the patient their colitis might be resolved. So I've been using more of the fecal calprotectin. I think that would be one of my take homes over the past year. But from supportive care, not huge changes other than that. It can be complicated. Look at those guidelines, especially ESMO and NCCN. They are updating them every year, sometimes twice a year, with the most up-to-date information.
Great. Well, thank you, Miss Sandy, for all this research and updates, and thank you for your time today. I really appreciate it.
Thank you for having me.